Hi, folks. Thank you so much for joining our webinar. My name is Sarah Castell. I'm the Operations Coordinator with the Maine Public Health Association. Today's webinar is Supporting Infant Feeding Goals in the First 4 Weeks. Before I introduce our panelists, I just have a couple of announcements. So this project is supported by the Health Resources and Service Administration of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. We do have CHES credits available in today's webinar. You'll need to log in and complete the webinar evaluation to receive those, to receive a certificate of attendance for those. Today's webinar is in partnership with the New England Public Health Training Center, the Maine Public Health Association, Maine Chapter of the American Academy of Pediatrics, and the Maine State Breastfeeding Coalition. Please feel free to chat in the chat or put questions in the Q&A for the panelists. And now I'd like to introduce our panelists today. Kara Kaikini is the Executive Director of the Maine State Breastfeeding Coalition. Paula Norcott is the co-owner of Maine Mother and Company, and Dr. Kelsey Walton is a primary care pediatrician at Kennebec Pediatrics. Kara, I will turn it over to you.
Excellent. Thank you so much. Let me get my slides ready to go. Share that. And then here we are. All right. Thank you, everyone. Thanks for being here today. My name is Kara Kaikini, Executive Director of the Maine State Breastfeeding Coalition. The MSBC is a 501c3 nonprofit. We're a welcoming and broad network of people supporting families who value human milk and lactation. And we are dedicated to supporting parents to meet their infant feeding goals through advocacy, education, and connection. So I'll be moderating today, sharing some information about the topic to start, and then I'll introduce our panelists before they address some sample cases about infant feeding in the first 4 weeks. We will open it up for more questions after that, and we'll share some resources as well. And for now, it looks like the chat box has some activity, so we really would love to hear who's here today, what kind of setting you work in. Are you working on the inpatient side, the outpatient side, both? And what part of the region or country are you from? We are really excited to be here with you today. So our objectives today are to review reasons why exclusive human milk feeding is recommended and its connection specifically to obesity prevention. We'll discuss appropriate weight loss and identify 3 tools for addressing higher than average weight loss for the exclusively breastfed baby in the first 4 weeks. We hope that you will be able to understand when to recommend pumping and or supplementing in the first 4 weeks of the infant's life. And like I said, wrap up with identifying new parent and professional resources for the breast and chest feeding parent. So let's start out with the American Academy of Pediatrics policy statement on breastfeeding and the use of human milk. They recommend that babies exclusively receive human milk for the first 6 months after birth and continue receiving human milk for 2 years or beyond. That was a policy statement that was updated in 2022, and I'll admit that I had some mixed feelings when they expanded that recommendation from 1 year to 2 years. I was pleased to see that human milk was being valued for that length of time. There's no time when cow's milk becomes better than human milk for human babies when it is available. But I was concerned about the pressure it would put on parents to meet that recommendation of 2 years when they're already struggling to meet the recommendation of 1 year. So let's look at some rates, just to give you an idea of where we're at and why we recommend as much as we do. These are the recently released breastfeeding rates for infants born in 2021. I have the US at the top, Maine highlighted because that's where we're in, the state we're in, and then some other New England states listed here as well. So Maine is doing better than the national average, though I'm sad to say that our exclusive rates recently dropped from 2019, just a little bit, but it's something to keep an eye on what kind of a trend we might be seeing going forward. All individual states listed here increased their ever breastfeeding rate, so parents who breastfed at all, and almost all went down for their 3-month and 6-month exclusive rates. Why are these rates going down? And those in particular, because we know that the barriers are not getting smaller. So we have this research showing why lactating parents stop breastfeeding early. Duration of breastfeeding is influenced by many factors, including issues with latching and lactation in particular. Concerns about supply, concerns about baby's growth, concerns about medications, lack of paid family medical leave, and then once they do go back to work, maybe returning to unsupportive work environments. We know that cultural norms and lack of family support also impact breastfeeding experiences, as do unsupportive hospital practices. And you can see here on the left that 60% of mothers do not breastfeed for as long as they intend to, and partly, mostly because of these issues here. We also have in Maine, and every state, I believe, has access to the Pregnancy Risk and Monitoring Survey. And this survey asks the questions, why didn't you breastfeed to start with? And if you did breastfeed, why did you stop breastfeeding? And these are questions, I always like the why questions, and I still have more why questions when I see that even though these are small sample sizes, that's something to keep in mind, that the majority of people didn't breastfeed at all because they just simply didn't want to, or they didn't like breastfeeding, or they had other reasons that weren't listed. I would love to know more about that, though we do know there could be many answers to those questions, including a history of sexual abuse or domestic violence, or as stated here, maybe a bad previous breastfeeding experience. So we always do want to be sensitive to that. The ones that I'm most interested in are the reasons for stopping breastfeeding. And so what's key to understand here is that people who responded to the survey could select more than one reason. And we can see that the biggest reasons here are related to concerns about supply, not enough milk for the baby, and concerns about latch or nipple pain. So this is really good for us to know as providers, so we know how to target support and education. We also recognize that parents are under a lot of pressure in so many areas of their lives. And so I always want to be clear that we, the Maine State Breastfeeding Coalition, and lactation consultants as a whole are not wanting to add to this pressure by encouraging breastfeeding. And we're wanting to add support to improve the systems around them to help them reach their goals. So that is something that is one thing I really want folks to understand and take away, is that we're not wanting to add pressure. We're wanting to add support. So you may have heard of this U.S. Surgeon General's advisory that was released earlier this year, and it recognizes the critical role of parents and caregivers in our society and the importance of reducing their stress and protecting their mental health and well-being. And we all have a role. So here on this list, number 3 is fostering partnership with community organizations that provide support and resources for parents and caregivers. And so we hope that that's something that you will see through this webinar, a conversation around that. And the second one, screening parents and caregivers for mental health conditions. So I did want to share quickly a little bit about that, because that can be very much tied in with breastfeeding support. Often the research shows that parents who are lactating parents who, when breastfeeding is going well, it can help prevent and reduce the risk of postpartum mood disorders. When it is not going well, it can increase the risk. So it can be connected. We want to recognize that and also help screen for that. And Postpartum Support International recommends either using the EPDS or the PHQ-9. They recommend that it is given at least 6 times between the first prenatal visit and the 12-month pediatric visit. So and there's some resources in the handout that I'll be sharing later on regarding that. And so again, we don't want to add pressure to these vulnerable families. We want to provide support and education to make it easier for them. And a systematic review was recently conducted to help the U.S. Preventative Services Task Force draft their updated recommendation on interventions to support breastfeeding. And they found that support and education provided during pregnancy and postpartum by professionals and peers is associated with an increase in the proportion of women still breastfeeding and exclusively breastfeeding at 6 months of follow-up. They add that more effort should focus on how to best provide this consistently for all individuals of all backgrounds who are making feeding decisions for their infants. They give this level of evidence a B grade, which is really great. This is also currently a draft, and they are still taking comments and questions regarding this draft for the next week or so before it becomes final. But we really were happy to see this, just more support around the importance of support and education. That's what we want to focus on today. We want to help you with that. We want to make you feel more confident in your ability to provide support and education to these families. We do only have this hour for now, but we are happy to provide more education in the future since there's so much to learn. There are so many topics that we could easily spend an hour talking about. From the reviews that they looked at, they did find that the association between breastfeeding and improved health outcomes in infants and their breastfeeding parent has been well established in observational studies. So recent reviews found a lower risk for acute otitis media, ear infections, asthma, elevated blood pressure in early childhood leukemia, type 1 diabetes, hospitalizations due to diarrhea, lower respiratory tract infections, dental caries, overweight and obesity, which we'll talk about in a second, and very importantly, the reduction in sudden infant death syndrome is one to be quite aware of. So in terms of obesity, we know it is connected to breastfeeding in two major ways. We know that human milk feeding has been found to reduce the incidence of childhood overweight or obesity. The longer, and this is also dose-response relationship, so the longer and more exclusive a baby is breastfed, the more protection against obesity for the baby. And it is also connected to maternal to reducing obesity risk for the mother as well when nursing. We know that maternal obesity has also been associated with shorter breastfeeding duration. So the risk of stopping breastfeeding early has been shown to increase as maternal BMI increases. So it's just something to be aware of. Research suggests that individuals with obesity may experience a delay in their milk coming in after delivery due to hormonal factors, and there may be a reduced prolactin response to infant feeding. So this is just another reason to focus a lot of efforts on obesity prevention in general and before pregnancy. There can also be challenges related to breast size and nipple anatomy, finding comfortable feeding positions, and definitely social stigma. So it is a group that we definitely are wanting to add extra support and information for. But what we're focusing on now is really the prevention and of childhood obesity and overweight. One of the studies shares that exclusive breastfeeding for at least 4 months had a positive effect on childhood overweight and obesity, and contributing beneficially to postnatal maternal weight control as well. So it's just another reason why we want to be providing that education prenatally as much as possible. And then some other recommendations related to this. So there's the CDC Division of Nutrition, Physical Activity, and Obesity. They list making breastfeeding easier to start and continue as their first priority on their website. In addition to promoting a healthier childhood, making healthy food choices easier for everyone, making physical activity safe and accessible for all, and investing in states and communities. And then the Maine Obesity Advisory Council also lists breastfeeding in addition to food and beverages, physical activity, community partnerships as goals to focus on looking at how to provide education to families and healthcare providers and improving environments for folks when they go back to work and also to be feeding in public. So there's a lot of recommendations for good reasons around feeding human milk and specifically to help prevent obesity and overweight. So next up, I want to share that our panelists, Paula Norcott and Dr. Walton, will review 4 different scenarios that will help explore determining appropriate or inappropriate weight loss, how to address that weight loss, and when and how much to supplement. Since if we're looking at what we talked about earlier with trying to increase our exclusive breastfeeding rates when possible without providing pressure, how to go about that conversation with families is really, really critical. And we'll end up leaving some time at the end for general questions and resource sharing, like I said. But first, I want to share a quote from a fantastic textbook that you might want to consider having on your bookshelves. They say that much has been researched and written about the normal needs and intakes of infants. When it comes to undernourished babies, however, we have only clinical experience and expert opinion to support common strategies regarding amounts for supplementation. So I bring that up now because what we're going to hear in these scenarios is that there's no black and white, only one right way to go about giving a supplementation recommendation. It also goes on to say that there are conflicting thoughts on whether allowing babies to gain weight rapidly to catch up to their expected weight could result in a permanently higher demand and a heightened risk for childhood obesity. Research into the long-term growth outcomes of previously compromised babies is needed to provide a firm basis for recommendation on how much milk is needed in the context of fueling necessary growth without overfeeding or underfeeding babies. So it's definitely something that we're still needing to do more research on. And in the meantime, we do the best we can with the information and the support we have, right? So we're hoping to provide some more information for you today. All right, so Paula, I'm going to turn it over to you to introduce our first scenario.
Awesome. So I'm Paula Norcott. I'm an international board certified lactation consultant. I wear a bunch of different hats. I worked bedside for years at both Maine General and Mid-Coast Hospital. I also do education for the perinatal outreach program with in conjunction with Maine Health in the state, and I'm in private practice. So I see a lot of tricky babies on the flip side post-discharge from the hospital. So what we're going to do is we're going to go over some imaginary babies. The first one is baby Opal. And we're going to give you the background and then talk through how Kelsey as a physician and I as an IBCLC might collaboratively work on this family, questions we might ask, and solutions we might come up with to help the families meet their goals. I want to reiterate that our job is never to force people to breastfeed, but it is really lovely when we can help families meet their independent goals. And a lot of times these goals are exclusively breastfeeding, and that benefits our community as a whole. So that's what we're looking at. There's no part of anybody on this panel who thinks that every baby should be breastfed. I mean, I love it, but it's about family choice and about those families having the support that they need to meet their own independent goals. So this is baby Opal. Baby Opal is 2 days old, ready to be discharged from the hospital, feeding well, according to the lactation team. This baby was born at 37 weeks gestation, prime-ip, spontaneous labor, currently using a nipple shield per parent request, 8% weight loss today, feeding about 8 times per 24 hours. The feeding parent states no pain or damage nipple-wise, feels confident with feeding. It's Friday. Okay, it's Friday at the hospital. Their PCP, their pediatrician, their doctor for their baby is not going to be open again until Monday. So how do we handle discharging this baby and what is the plan? So Kelsey, why don't you introduce yourself and we can kind of talk through this a little bit.
Can everybody hear me?
Yes.
Oh, good. Okay. I'm Kelsey Walton. I'm a pediatrician at Academic Pediatrics in Augusta, and I've been in primary care for just over 2 years now. Prior to this, I was a pediatric hospitalist at Maine General in Augusta, Maine, where we take care of a lot of newborns and have a tiny little level 2 NICU there as well. So hopping right into the case. So baby Opal, and I also want to reiterate that I think lectures like this are so important, and my hope is to convey a little bit that we all talk about this because there isn't a cookie cutter way to do this, and it's very family dependent and baby dependent, and so each situation is so unique and has to be interpreted in that specific situation. And I wish there was a chapter in a book. I think that's what Kara and Paul and I all kind of realized this last week, is that there's no chapter, there's no like perfect way to do all of this. So I'm glad we get to be here to talk about these cases today. So for baby Opal, 2 days old, breastfeeding, sounds like feeding is going well. When we talk about discharge planning, so the AAP recommends a follow-up for newborns from discharge from the hospital within 48 hours, which can oftentimes be difficult if the primary care office isn't open on the weekends. So when I look at baby opals, weight loss, 8% weight loss today, which, you know, at first glance seems like, oh, for a 2-day-old baby, that seems like a lot. Here is where I want to put in a plug for the newborn weight loss tool, which is a great resource online that has baby norms based on breastfeeding, formula feeding, C-section, vaginal delivery, and you can pop in all the information and it will tell you a percentile of weight loss you're at today. So I put in like 48-hour-old baby, and 8% weight loss is just under 75th percentile, which is actually seems pretty good for a 48-hour baby. That doesn't make me nervous, doesn't give me palpitations yet. So I'm very based on that, I would say the routine AAP follow-up within 2 days would be good. During the follow-up with the primary care physician, which I think is so important, which we'll talk about in a few minutes as well, that we can check in back in on feeding and make sure that feeding is continuing to go well as a very important time where, you know, milk is coming in, breastfeeding is being established. So here in Augusta, what we generally do is our office we see babies on the weekends. So a lot of the surrounding primary care offices know that. And we will often see babies in our office who aren't going to necessarily be our patients. And that's kind of how we get around when the offices aren't open on the weekends to newborn discharges. Follow up with lactation can also be important too on the weekend. So if you don't have access to a pediatric office such as ours, if you can do outpatient follow up with a lactation program on the weekend for a weight. But I do think, you know, especially, you know, a breastfed baby, we're at 37 weeks. Sometimes 37-week babies can be a little bit creepy pokey with feedings. They're using a nipple shield. So there's a little bit of, you know, things that aren't super perfect, but or super the norm. But I think that follow-up is really super important.
Yeah,
What do
I
you
agree. Yeah, I agree. I think nipple shield use is one that comes up a lot. I think it's important to recognize this specific case, particularly this is a parent requested nipple shield. And so I think it's important for people to understand that this family may want to use this nipple shield forever. Or this family may want to get rid of this nipple shield as soon as possible. So asking the questions of why are we using a nipple shield? Like, tell me more about how the nipple shield came into play. If you get an answer response of like, oh, I want to use it, I just like it, I encourage you to let it be as it is for a little while. And the reason is that we have seen a trend in lactation where parental requests nipple shield might be correlated to history of sexual assault. So for some people, having that barrier between them and the baby makes it feel comfortable for them. And so for the most part, nipple shields are not a problem. I think this family needs a little bit of a closer eye on them. So regular weight checks, making sure that all of that is going well. And then the other piece that stands out to me here is also the 37-weeker. If you've worked with late preterm babies, it can go any way. We have no idea what it's going to look like until we know what it's going to look like. So for this baby, I think, you know, a conversation that I might have had in the hallway with Dr. Walton about this family would sort of be like, do we think this baby needs a weight check at 24 hours? Or do we think this baby can wait 48 hours? And that's when Dr. Walton would use the Newt tool and take a look at what this means for this baby. And we can determine that, because sometimes we'll have them come right back to the hospital or come in, if, you know, if their physician is available, have a weight check at 24 hours. We can also pull in public health nurses when appropriate. I saw a lot of public health nurses on here. You guys, you're some of my favorite humans. Thank you so much for what you do. That is another opportunity for additional weight checks on a baby. And 8%, you know, the norm, we know that babies can lose up to 10% of their weight, and that's pretty normal depending on when that is. So 10% of their weight at day 1 versus 10% of their weight at day 3, those are very different. And so this is where the nuanced care really comes in. I also, you'll hear me say it 72 times today, that an interdisciplinary team approach is imperative because nobody knows everything, nor do you need to. And one of my favorite parts about working at Maine Gen especially was we had such great collaborative care with our pediatricians. We would huddle often on babies, peds, lactation, nursing staff. We would all get together and really kind of work out what is the best scenario for this family. So this one feels like fairly straightforward, but also I'm a big fan of a weight check once a week for 4 weeks for a couple of reasons. I know this doesn't always work for people, but if you pull in public health nursing, if you pull in lactation, if you pull in the peds team, and some of our hospitals here and in other parts of the country will do clinics at the hospital or support groups as well, where there's a scale available, it can be pivotal to a parent's confidence in how feeding is going if they're able to see these weight checks pretty regularly for 4 weeks. It also avoids the sort of panic where we saw our baby 2 days post-discharge and then 2 weeks down the road and a lot shifted. And it's, to me, when a baby doesn't gain appropriately in the first 4 to 6 weeks, that's a system error, not usually a parent problem. It's us, like they don't know what they're supposed to be doing. Some of these babies are meeting all the requirements, check boxes, milestones, and they're still not gaining weight appropriately. And it's devastating to parents. So if extra weight checks are an option, I'm a big fan of extra weight checks. I am not a big fan of families buying their own scale. That's a different scenario. I think we'll do Q&A at the end, so throw your questions in there for sure. But why don't we, next case, yeah. So this is baby Juniper. P.S. I picked all my favorite names. These are all my favorite baby names. Baby Juniper is 4 days old, born after a 4-day induction, vacuum ×3 delivery. So that could be a little stunned baby there. 4-hour pushing phase, that's long. Naked weight today shows 11% weight loss. So this is a baby who's come in for their 2-day post-discharge weight check at their pediatrician's office. Parent states feeding is going well, some chomping, some nipple tenderness. Baby's eating 9+ times per day average. Mom states baby has 6 wet diapers a day, 6 wet diapers in the last 24 hours and 4 poops, but is at 11% weight loss. So Kelsey, tell me what questions you would ask this family.
Yeah, so these are my favorite appointments. So I love this 2-day, as you may have noticed, 2-day discharge appointment so much because in the hospital, parents have, they can call for a nurse or a lactation consultant, there's a physician, there's all sorts of people and resources. And then we set them free into the world and they go through this period where they have this new human being that is fitting into this life they previously had, and how does that work and what sort of new experiences, and suddenly we're not sleeping in our bed when we used to sleep all night in our bed, and it's just such a change. And for a lot of people it's blissful, for a lot of people it's traumatic, in addition to the trauma or blissfulness of a delivery. I would say for most parents it ends up somewhere in between. So I love just sitting, this is a great appointment to put the computer away and look at your patients in the eye and talk to them about how they're feeling about things and reflect a little bit on the delivery. So this mom pushed for 4 hours and had a vacuum delivery. How are you feeling? How did everything go? How are you feeling? And do a little bit of trauma-informed care at this visit. It's so wonderful. And it's really hard to do when before we go in the room, we know that this baby is down 11%, and we know that maybe feeding is not going well. And so we have to have some tough conversations. But going in there and reflecting on things first and creating a safe space to discuss these things is so important. So then getting to the weight breastfeeding side of things. So how I would approach this is before I come up with any sort of feeding plan. So feeding plan is at the end. We need to figure out how breastfeeding is going. So the questions I generally ask are, tell me how breastfeeding is going. Tell me about the latch. Can you hear me?
Yeah, it's a little
Okay.
muffled. It's a little muffled, Kelsey. I wonder if
Oh.
you come a little closer to your
Yeah.
microphone, it might be better.
Is this better?
Yes.
Okay, good. So tell me how latch feels for you. Are you having pain with latch? I think there is definitely a out there that breastfeeding is going to be painful, and so a lot of moms say, yeah, it's painful, but that's okay, that's normal. But delving into that a little bit more is so important. So what sort of pain are we having? Is it at the beginning of a latch? Does it get better throughout? How does that pain change, and what does it feel like during a latch? Do you hear swallowing? Do you feel like your milk is coming in? Are you feeling fullness, more veining, that sort of thing? How are those poops looking? Are they still meconium colors? Are they still sticky? Have they changed? Are they yellow seedy now? How is that looking? All of those things can really help give you an idea of how feeding is going. And then the other thing, you know, if moms say that milk is coming in, then really assessing transfer, I think, is a good idea too. So, you know, if you feel like you have putting baby to breast on a full breast, does your breast feel softer, more empty afterwards? What sorts of changes? How can we assess the transfer of milk? So depending on the answer to those questions is really going to guide how we decide on a feeding plan. I think asking the question, what are your goals for feeding? It's so super important, because that, whatever family's goals are my goals. Even if we have to talk about not getting to that goal today, but that goal eventually, having that process in mind, getting to the family, meeting the family's goals is going to be super important, and making sure the family knows that too. That's important to me. If you want to just breastfeed and have baby at the breast, that's important to me, and that if it's important to you, is important to me, and we're going to get there. So the answer to this baby is going to be a little bit different for me. Say milk is coming in, I feel pretty good about transfer. You know, let's see, milk just came in last night. Let's see what a weight looks like again tomorrow. Or if latch seems really uncomfortable, I have a concern about transfer of milk, we're still having meconium poops, then maybe we need to make another plan. And so the plan for supplementation for me is really going to depend on how ineffective I feel like the lactose and transfer. So it may be anything from let's pump and supplement to hey, I'm not sure. I would offer formula. I would offer options. So as far as supplementation, some moms do not want to pump, and I'm fine with that. Then we have to talk about another option. So it really depends on what families want. And also keeping in mind too, I'm assuming this is a very healthy looking baby in front of me. If you have a not healthy looking baby in front of you, then we have to start thinking about other things. But assuming this is a healthy looking baby, it really just depends on that assessment of feeding and the family's goal. That's
Yeah.
great.
Yeah,
Yeah.
I totally agree. A couple of things that I want to reiterate is the questions that you ask and the way you approach it is so valuable to the outcome as well as the experience, right? So we have obviously, I don't know, I've yet to meet a person who didn't want a baby to gain weight really well. Like that's everybody's priority, and it's always the parents' priority. And I think that's really important to understand, that nobody wants this baby to thrive more than the parents do for the most part. This baby's been through it, right? So has the family. 4-hour pushing phase, really long induction. I also think something to note, a long induction often means a lot of IV fluids. And so, you know, that initial weight might be somewhat inflated if it was taken an hour or like within the hour of delivery. 11% weight loss is high for what we consider to be normal. And the question that you said, Kelsey, that is everything to me is, do you feel like your milk is in? So we're asking the parent, do you feel like you've transitioned into mature milk? Do your breast feel heavier? Do you feel like the baby is swallowing more? That's really important, because if the answer is no, and then you might move into like, have you pumped it all? Are you getting anything? If we don't feel like the volume has increased in this parent, it's probably time to supplement. right? It's probably time to talk supplementation with, you know, it might start with a pumping conversation. It might, we might talk about donor milk. We might talk about formula. But that piece is so important, especially at the 2-day post-discharge weight check almost always falls on the day that the milk comes in, almost always. So what happens is babies are maxing out their weight loss on that same day. They sort of plateau the day the milk comes in, and then very often the next day they've gained an ounce. And so putting in a plan that waits for another weight check for a week is a really long time where things could go so many different, not great directions, right? So if we can get a weight check in 24 hours on this baby, that would be amazing. And then, oh, nipple tenderness and pain. I don't know. I'm curious. I would love to know how many pediatricians ask about nipple pain, because it can very often be related to other problems. And I think that link is not always understood, where if a parent has pain and we have high weight loss, we could have a transfer problem. We could have a baby who's working really, really hard and not getting enough calories. And it might not be a supply issue. So it's super nuanced. And for me, this is a baby who, if we do a weight check in 24 more hours and things haven't improved drastically, needs to probably see lactation, right? Like, what are the next steps? 9 times a day is a great amount of time for a baby to eat. 8 to 12 is the norm. 6 wet diapers on day 4 is pretty good. And 4 poops is good. And color of poop is also really important. Are we transitioning? You know, the poop transitions while the milk transitions. So does it look like all is well? I would say there's a really good chance that this baby comes in 24 hours for a weight check and has gained 20 to 30 grams and, you know, is guzzling. I also think a really important, assessing a feed, if you've never done it before, is maybe not like the right step for everybody unless you know what you're looking at. Pre and post weights are another tool, but only when used appropriately. So pre and post weights should always be done in grams, and it should be done by someone who really knows and understands a pre and post weight, because there is a right way to do it. And then I just had another thought. Oh, I don't remember. That's okay. Welcome to my world. Anything else, Kelsey, or any thoughts on this baby, Kara?
Yeah.
Yeah, go ahead.
Do you mind commenting on swallowing?
Yes.
Yeah.
That was it. That was the other thought. I remember.
Yeah.
Yes. So assessing a feed, especially when we talk about transitioning from colostrum to mature milk. So colostrum nursing, like when a baby at breast with colostrum, their suck swallow ratio might be anywhere from, 2 sucks to a swallow to 8 sucks to a swallow, depending on the day. Colostrum's thick, it takes more time to move. So that suck swallow ratio is very different. But when we transition to mature milk, it should typically be 1 to 1. 1 suck to 1 swallow for the vast majority of a feed. Anything over 10 minutes for a feed pretty much counts. All babies are different. Yes, baby. I had a baby who only nursed ever for 9 minutes, and he was the Stay Puft Marshmallow Man. He was big. And that's not everybody's story, but it's not about 15 minutes on each side. It's about 10 or more vigorous minutes and an appropriate suck swallow ratio. It's the number one thing that I'm looking for when I assess a feed. So, and this is where it's tricky for parents, and this is so important. If you have a baby who's suck, from the parent's perspective, all looks well. That baby's not asleep, or it might be sleeping, but is vigorous, is staying on the breast for, at least 10 minutes, sometimes 20, sometimes 30, meeting their output expectations. But if the suck swallow ratio is 3 and 4 to 1, we have a problem. So they don't know. And I think if you're a bedside nurse, if you're a public health nurse, if you're in any position that you get to actually observe a feed, pointing out the swallows to the feeding parent and family is one of the most important things you can do, and explaining a suck swallow ratio. I get the best feedback from my families who were taught in the hospital, this is what a swallow looks like. And I can say, how many sucks to a swallow do you think your baby's doing? this baby never swallows more than every 3 sucks, or every, like, guzzling, chugging, like funneling is one of my favorite explanations that people say. So that piece is so imperative, and it's okay to not know what you're looking at. It's okay. You just have to know who to refer to and how, and get them in as fast as you can. And worst case scenario is have them pump a little bit and see what they get. You know, like, a bottle's not going to break a baby. If we need a baby fed, that would be my first step, is like, okay, we need to supplement. Why don't you pump and let me know what you're getting, and we can decide if we need to add in anything else.
Yeah, that might come up, I wonder, in another scenario to talk more about that, Paula. I think the suck swallow ratio piece is important to really understand and to learn more about that. If anyone is like, I don't know if I can take a whole certified lactation counselor course or IBCLC course, but I want to learn more about that. I think that would be really helpful to understand that timing of that, because not every baby is going to, right? Babies that are at the breast for 20 or 30 minutes, that's okay. They're not doing a 1-to-1 suck swallow for that entire half an hour probably, and that's okay. And some babies do just take longer with a different ratio. If the mom's okay with that, that's okay. That might change with time. It could also be a sign that that something else is going on, and that mom's not going to be okay with that for very long. So these regular check-ins that you mentioned, I think, are so important around that. And the other thing I'm thinking about this family is that this is a great time to ask what kind of support they have at home. What do they have a doula, or do they have access to a postpartum doula in the area? If they don't have a lot of family, that can be truly helpful at home, because yeah, the 4-hour pushing after a 4-day induction, they're coming back at 4 days. They're maybe coming back on the 5th day for an appointment. Like, it's a lot. It's a lot for these families.
It's a lot. And this family should not have another appointment until 2 weeks.
Right.
I think that's really important. When we hit 11% weight loss, we need extra eyes here. I agree. And I'm from Maine, and we have an amazing public health nurse program, and it's free to anyone that has a baby in this state with no income requirements. So I'm a huge advocate for that, because that additional support can be pivotal. We also have Maine Families, WIC, peer counselors. That's how I got my start in this world, is as a peer counselor. There are free resources. One of the things I love about the peer counselor program is they typically have oversight and help from an IBCLC somewhere that they can pull in if they need to, but also they can do a lot on the phone. And so, I got my first 10 years were only phone counseling. So I have really honed in on how to understand what the heck is going on with a baby and a family without being able to see either of them with my eyeballs. So usually peer counselors have got some really good skills and then know when they need to refer out.
Mm-hmm. Awesome. All right, we're going to move on to the next scenario.
Baby River. So baby River is 2 weeks old. So this is at their 2-week checkup with their pediatrician. 4%, still 4% below birth weight. Seen 2 days post-discharge and had gained an ounce since leaving the hospital. So that's great. Parent states baby feeds 12 to 16 feeds per day. It's their second baby. They exclusively breastfed their first child for 6 months. Amazing work. Feeds are short. Baby falls asleep often after just 3 minutes of nursing. Baby has 6 to 8 wet diapers and 2 yellow poops per day. This is a good one.
It happens all the time. Okay, so usually by the 2-week appointment, I expect babies to be at or above birth weights. So baby River being at 4% below birth weight is less than I would expect for a baby. So my approach would be similar to the last one. We go in and start ask all the questions to assess latch and transfer. I'm already worried about baby not adequately transferring milk. So since we haven't regained our birth weight, well, 16 feeds in a day is a lot of feeds, especially with them being short. Oops, sorry about that. So I always think of feeding in infants as the most amount of exercise we make them do. And feeding is really, we want to get to a point where we're taking in more calories than we're expending. So having feeds that are really a lot of bang for our buck. So a lot of calories for our exercise is how we end up with weight gain. This is a baby where, I would be calling up my friendly lactation consultant to say, hey, I'm worried, there's something going on here that's not working for baby. And having them seen pretty quickly. This is also a baby where we probably need to start talking about supplementation. So, depending on what mom's preferences are, starting with some supplementation, either with some pumped breast milk. If they have access to donor breast milk, that's great. If they don't want to do either of those things, then we have formula. Also recognizing the fact that when we set up feeding plans for these babies, it is a lot of work. So if we continue to have babies, so that your classic like triple feeding or having mom put baby to the breast and then give and pump and put breast milk in their bottle, and then it's a lot of work. It's like 2 full-time jobs. I always talk to moms about this as, hey, this is a bump in the road. What are your goals? If your goals are exclusive breastfeeding, this is going to get us to the point where we want baby to be gaining weight in a way that we expect, which is somewhere around 1 ounce a day. And getting to that point where they have enough strength to really, and we work on latch, get the transfer of milk a little bit better. And then your lactation consultant can help you with, assessing milk supply and that sort of thing, along the way as well. So this is gonna be a little bit of a process. But always keeping in mind what the family goals are and getting back to those goals at some point. This is also gonna require weight checks. Yep, so the way I usually do this is depending on how quickly lactation can get them in. Usually our lactation consultants are great about getting me a weight. Sometimes I have some babies who are seeing PT, OT, and I just call the office and say, hey, while they're there, can you get me a weight? Just to save families time. Sometimes it's just a lot of appointments. It's a lot of work and a lot of appointments, but so that's usually my general approach for that.
Yeah, so this is a super common case in my world. I see this almost identical scenario a lot. Not back to birth weight at 2 weeks is definitely a reason to be like, let's really dig in and see what's going on. And what my concern is, the thing that I've got in my head instantly about this family is that this parent has already exclusively breastfed a baby successfully for 6 months, which means it's probably not a supply problem. It's probably not a supply problem. If second time around, typically you make more milk faster for most people. And I want to protect that supply while also making sure the baby's getting fed. And so this is where it gets really tricky with how are you supplementing and how are you following up and what's the plan for the parent, right? Like what's pumping look like for the parent or breast stimulation to make sure that that volume is continuing to increase like it's supposed to. Typically families, like a feeding parent will max out their volume around 4 weeks, 4 to 5, I would say, if all is going well. It might take a little bit longer if it isn't, but what can happen is if the demand isn't there. So if we have a baby here who's nursing but not pulling efficiently and effectively, the body's not getting signals to increase volume. So in order to give this family an opportunity to exclusively breastfeed, if that's what they want to do, we have got to get that volume going up at the same time that we get the baby gaining, right? So it's a little complicated, and I think a really great project for a skilled IBCLC, because this is what we do all day. So what if you don't have access to that? How would you handle this? So pumping is definitely my go-to. Triple feeding, if you don't know what it is the worst thing ever. It is feeding a baby. So sometimes it'll be like, feed the baby at breast for right, Rachel, right? For 15 to 20 minutes, then pump for 15 to 20 minutes, then feed back whatever you pumped to the baby. I think that's cute for like 24 to 48 hours. And then I think you have families who aren't eating, peeing, or sleeping. And so, but we have to protect the supply. So for me, the way I would handle this is I would say weight check in 24 hours, hopefully with lactation if possible. And in the meantime, I want you, this is what I would expect this baby to take per feed by volume, right? So at 2 weeks old, I'd expect to see a baby taking 2 to 3 ounces. So I might just say like, let's do 2.5. Chances are this baby's never gotten 2.5 ounces, which is why they're not gaining weight properly, right? So that's probably more than they've been getting. So I would say about 2.5 ounces per feed. Put the baby to breast once a day. The rest of the feeds for 8 feeds a day, I want you to pump and bottle feed until you go to lactation tomorrow. We get another weight check. Because now, let's say we do this, baby, mom's able to pump 2.5 ounces, baby's able to get 2.5 ounces, that baby gains 45 grams overnight. We now know it's a transfer problem, right? It's if the parent doesn't have the volume, it's probably a supply problem, but could be also a transfer problem that's led to a supply problem. It's really nuanced. And that's why, you know, when you're a pediatrician and you've got a 15-minute visit max, where you have to do all these bits, it's complicated to get it all in. And that's why you utilize your interdisciplinary team. I'm seeing this great trend of pediatric practices pulling in IBCLCs on staff. And imagine if you could step out of your visit as a provider and call in an IBCLC to be like, this is what I'm seeing, this is what's going on. Do you have a minute to meet with this family right now? It is covered by insurance. It is billable. It is a huge add to a practice. I think it's really amazing. Not everybody has that opportunity. Falling asleep at breast at 2 weeks old is a big red flag for me, especially we're seeing like 3 to 4 minutes. So basically what you see is this baby's having a letdown, parents let down milk, baby's swallowing through the letdown, and then they can't pull any milk after that and they're falling asleep. So this is like, there's so many red flags here for like lactation, lactation, right, Kelsey? Yeah. And you might have a parent here who's like, oh, my plan is to combo feed, no problem. We had always intended to give a little formula. Great, that's an easy step. We still have to figure out what their long-term goals are. If their long-term goal is a full supply of milk, we have to protect that. You might have a parent here who, this visit is very emotional because right? Because they think, okay, back to birth weight by 2 weeks, and then they're not hitting it, and they already feel terrible. So choosing your language carefully is so important. Like, not, you want to say things like, what are your goals? And then talk about supplementing as a bridge to meeting those goals. This isn't a this or that. Like, if you have to give your baby formula, you are not in a we're not breastfeeding anymore category. It's a bridge so that baby gains. Often when we boost a baby's calories, there's stamina boost. So it could be that, right? We have to kind of look at this in a very nuanced way.
Awesome. We have 6 minutes left in this webinar and another scenario and some resources to share and a couple of questions. So let's see if we can go to the next scenario and answer this one as quickly as you can.
Sure, great. Baby Isla, 4 weeks old, averaging 13 grams a day gain. I can't wait for everyone. I want everyone to put in that chat box what they think appropriate weight gain for a newborn is, because in the research, I can't find anything consistent. Babies meeting normal developmental milestones. Parents state baby feeds 8 times a day, including nighttime nursing, 40 to 45 minutes each feed, 6 to 8 wet diapers, pooping every 3 to 4 days, has gone several days without pooping. Parents have expressed a strong desire to exclusively breastfeed. Transportation is a challenge for this family, and they're not interested in a public health nurse. Before I let Kelsey go on, I'm just going to say, I'm going to try real hard to convince them of all the benefits of the public health nursing program.
All right, I'm gonna try and talk fast. So 13 grams a day. I would say looking at the average weight gain charts for what we would expect at this age, on average, we're talking around an ounce a day, plus or minus, depending on what chart you look at. 13 grams a day is definitely not enough. So first of all, from my standpoint, I'm looking at the baby as far as what medical things I could be missing. So metabolic disease, heart disease, are we having any symptoms, signs of those things? And assuming that this is a very well appearing baby, then we're assessing feeding. So my red flags in here, feedings are long, but And then I would ask about latch transfers, same sort of principles we talked about with our last piece. Again, assessing, trying to get an idea of how we're doing supply-wise. Has mom started pumping? Because at this point, if we have a baby who hasn't been transferring very well for 4 weeks, this might be starting to impact supply. And then same sort of principles, what are the family's goals? How can we get to those goals? This is gonna be a tough case because transportation is a challenge, and we're obviously emphasizing weight checks and frequent assessment of babies with feeding issues. So working with the family as far as what can we do for weight checks to meet their goals and super important.
Yeah, I think weight checks are complicated. I mean, I will straight up ask this family, like, tell me more about your concerns with a public health nurse coming to you. What we see here in the state is that very often it's that public health nurses are affiliated with DHHS, and that sends up red flags for families. And so talking through that with them is something that I would approach. I love it when people locally know who their public health nurses are so that they can say like, oh no, I know Jessie and she's incredible and I can't wait for you to meet her. And, you know, she's great with babies and blah, blah, blah. It's even better if you actually know specifically who you're referring to. This baby is nursing 40 to 45 minutes are really long feeds for a 4-week-old baby. And that's when I want to know, like, are we vigorous for 45 minutes? Are we vigorous for 2 to 3 minutes? And then we're snoozing and long pauses. This is one of the things I ask about, like, how long are the pauses? They're really long. You know, sometimes it'll be like a minute and then do the sucks look like this or do the sucks look like this? So I call these butterfly kisses, and these ones are these big vigorous sucks. Oh, lots of butterfly kisses. Okay, we have a baby who is struggling to move milk here. And so again, automatic IBCLC referral, because they're the ones really good. And remember that IBCLCs get an hour with their patients. So I love we're starting to do the how many grams per day gain is appropriate. This is so fun. I want, we want these families to have all the support they need. And again, similar questions to the 2-week-old baby, but this visit tends to be even more devastating if at the 2-week visit, everything was fine. And then at the 4-week visit, it isn't. What has shifted? What type, do we have pain with latch? Do we have misshapen nipples coming? Like, those are related very often. Do we have a baby who has torticollis and is tight and a little bit twisted? And, like that alone can impact how a baby transfers. 13 grams a day. So that's not enough, right? So I will tell you that I was taught in my education 15 to 30. ABM states 20 to 30, and I hear from many pediatricians at least 30. So this, and then trying to pull in true hard resources with data and evidence on how much weight gain is appropriate seems to be way more complicated than it should be. And this is part of why the parents are getting different information from everyone.
Right. And as we've said, not every day 3 looks the same for every family. There's so many questions to ask to really drill down into how things might look in another day and to check in another day. Yeah, I'm mindful of time, so I do want to address at least the first part of Ruth's question. I will get to a slide in a moment that will have a QR code to resources for you, so you can find some more information about the obesity research that I stated. But Paula, Kelsey, can you answer?
It's donor milk, donor.
Okay. You did not say donut milk. I wondered.
Probably sounded like that. PDHM,
okay.
pasteurized donor human milk is what we're referring to.
Thank you. And Rachel's question around other services that can come into the home. I think we all wish that there could be a lot more. We're so grateful for public health nursing. There are some, depending where you are, we have a lot of people from around the country. There might be lactation consultants who can come to the home as well. We would love to see more of those options.
Some states have coverage for postpartum doulas also. So that's another option. And then depending on the family and their resources, what they can and cannot afford and swing support groups. La Leche League meetings. WIC often will have support groups. Peer counselor program can be on the phone. Lots of things.
Mm-hmm. Excellent. And so this slide has that QR code, has a website. Oh, I'm seeing that there's a B there that is hiding at the bottom. For you to see it, 2 to 3 pages of resources for you, including the Academy of Breastfeeding Medicine protocol for supplementary feedings and the NEWT, that newborn weight tool that was referenced earlier. I wanted to do some shameless plugs about some resources Maine Breastfeeding Coalition has too, regarding support directories for groups and for professionals. You can find those all on our website. And I'm going to skip through these awesome workplace resources and those slides are looking fun, as well as a reference for professionals around supporting LGBTQIA2S+ families. And then our contact info is here. So please jot that down before you go if you can. If you have any other questions, please reach out to us. Thank you, Kelsey and Paula, for being here and sharing so much. There's definitely, this could have gone on for another hour. And thank you everyone for joining today.
Take care, everyone. Thank you.
Thank you.